Okay, now let's just do the last little bit of our reproductive section, and then we are all done. One of the last things we're going to talk about is gonorrhea. Gonorrhea, is, of course, is a sexually transmitted disease, or an STI, or a sexually transmitted infection, mostly going to be spread through sex. It can also come, especially when we have a mother that has an outbreak of gonorrhea. So if especially for vaginal birth, not really going to be such a thing for cesarean sections, but for vaginal births, it can be exposures, things like mucous membranes making contact during the actual birth process. And it's going to be a gram-negative bacteria, so it's not going to accept gram staining. This is what you're going to see. You're going to see mostly pus. Pus is a pretty big indicator for gonorrhea infection in both males and females. When we're talking about this you're actually looking at the cervix. So this is actually this milky white solution that's coming out is pus of an infected cervix. Right, obviously that's going to be really red, it's going to be really itchy, it's going to be painful. So especially when we're talking about males, it's going to be especially painful to urinate because the urethra is inflamed throughout this, right? You have an infection. Something that doesn't get talked about as much, but is certainly a big deal, is that nearly a quarter of women that actually have a gonorrheal infection tend to have these kind of long-term sequelae. So these are going to be like long-term symptoms, side effects, damages because of the infection. So it can lead to things like infertility, right? That's a pretty big deal, especially if we're just talking about a person that would like to go and have kids. Other complications that you're going to see with gonorrhea is epididymitis, right? So the epididymis is going to be this section that's kind of hanging on the side. So this epididymis becoming heavily inflamed. So this is not the testy itself generally is not going to have like hydrocephalus or hydrocele or anything like that, but you can see inflammation in the epididymis, so much so that it actually can cause damage and end up having to have this thing resected, right? You're having to take out this testy. And any kind of frothy discharge tends to be kind of a greenish color in gonorrhea, which is a little bit more indicative of gonorrhea versus other STIs. But certainly you could have co-infections with other things, so it couldn't necessarily always be just gonorrhea. And that discharge is pus-filled because obviously we're recruiting a lot of neutrophils to come in and fight and die and kill it and try and attempt to kill that gonorrheal infection. Gonorrhea is something of a special STI because it has this kind of unique ability to evade our ability to actually mount a B and T cell response to it. So our adaptive immune cells, the lymphocytes can't really target it. And it does this in a couple different ways. Most notably, remember, B and T cells are going to be targeting the surface protein. So if I'm like drawing a little protein that's hanging out on the surface of this gonorrheal bacterium, right, the B cell that goes and looks for that particular antigen, well, now all of a sudden, if I change the shape a little bit, right, if my next generation of gonorrhea, the next bout of infection is going to be a slightly different shape. So now it's not this block shape, but it's kind of a block with a little change in it, right? So some change on the surface protein. Now all of a sudden that B cell and that T cell, that antibody, right? So if I'm producing antibodies that go up against and target that particular thing, right? Because I have immunity because I had gonorrhea previously. Well, now all of a sudden my antibodies are going to see this and aren't going to know what that is. They're not going to treat that as if it's a past infection. It's still gonorrhea, but the antigen that is initiating that immune response is different. It's not there anymore. Obviously, things like complement proteins, if you're able to inactivate complement, that's a great way to stop you from mounting an immune response in the first place. And part of the mystery of this is we actually have a little bit of idiopathic change where we don't really know why, but somehow gonorrhea is able to stop the production of secreted antibodies. So the antibodies that are secreted out, and there's a little question. I'm not going to bother. I'm just going to give everybody credit for this. Remember, the IgA is our secreted antibodies. IgM is going to be our first that we're generating. IgG is going to be our long-lasting. IgE is going to be the antibody that we mount against helminths, large multicellular parasites. IgA antibodies are going to be the ones that show up in places like the gastrointestinal tract, the mucous membranes, things like the urethra, the vagina, as well as in the milk, right? So in particularly in the breast milk right after birth, right? So that's where we're going to see a lot of these IgA antibodies. If you have a gonorrheal infection, you stop this IgA antibody initiation. Well, hey, that if you don't have those mucous membranes covered with these antibodies, that makes it a little bit better of a place to live if you're a gonorrheal infection. Compounding this is occasionally if you start to see dissemination of this gonorrheal infection, now all of a sudden you're not going to just have the mucous membranes and the genitals being infected, but now you can enter into a septic infection where the gonorrhea disseminates around the body, or DGI, right? Disseminated gonorrheal infection. This person has a gonorrheal conjunctivitis, right? The eye has become infected. This is going to be a big deal, and obviously there'd be even more organ systems being infected inside. So that's a problem, mostly because the fact that gonorrhea is so good at evading our immune system, we can't rely on our adaptive immune response. So how do you treat gonorrhea? Well, you give someone antibiotics because they don't have immunity even if they've had gonorrhea before. Well, now all of a sudden you start dosing it with things like penicillin, right? That first antibiotic, right? We started to see penicillin resistance showing up pretty rapidly in gonorrhea because we're using so many antibiotics. Now all of a sudden we are dealing with these super versions of gonorrhea that now we don't really have an ability. There's no antibiotics that are able to target a lot of the gonorrheal infections. We kind of have to rely on a patient's own immune response coupled with an ineffective antibacterial response. So that's a pretty big problem. Gonorrhea is a few years ago, the Ohio was actually the third highest per capita incidence of gonorrhea. That part of the reason behind that is gonorrhea is raging in a lot of nursing homes. So it's a big deal. There's a lot of unprotected sex occurring in nursing homes because obviously you're not going to get pregnant. You're not worried about things like HIV because you're not going to be old by the time that you develop AIDS. You're going to be already dead from old age. So there's a lot of unprotected sex, unfortunately, in nursing homes. So there's that image for you. The next thing that we're going to talk about is prostate cancer. This is that's not adenocarcinoma. This is an adenocarcinoma. Adenocarcinoma is going to be the endocrine exocrine tissues, so the things that release and secrete things out into the tissue around them. And this is going to be a cancer that generally is not going to be one that's not actually that harmful. But the problem is we have this kind of difficult to reconcile thing, right? The fact that lots of people die of prostate cancer, right? It's the second most common cause of man dying from cancer, coupled with the fact that if you look at any one individual prostate cancer, most of these are not actually that big of a deal, right? Most prostate cancers are not going to be highly aggressive. They're not going to be rapidly moving through staging and starting to metastasize around the body. Most prostate cancers are generally fairly benign. And the reason for this is the fact that these are very common. So even if a relatively low percentage of these end up being a risk of mortality, the fact that pretty much 1 in 4 men are going to develop prostate cancer, and this is obviously only in men because only men have prostates. 1 in 4 men develop prostate cancer at some point in their life. Obviously, that's going to lead to a lot of cancer deaths. So why does someone develop prostate cancer? Well, we generally don't know. It's a very poorly understood, which is kind of saying something, describing how common it is. We think it may have something to do with testosterone, right? So there seems to be an effect in testosterone. There's a lot of studies that have gone out and said red meat increases prostate cancer risk, but there's other studies that have said there isn't an association between that. So we're not entirely sure. And BRCA2 malformations, remember BRCA2 malformations is one thing that shows up in a lot of breast cancers. So this is that gene that's responsible for a lot when you start to have BRCA2 fail. It's one thing that you see in a lot of breast cancer. So it's a similarity there. So one of the ways that you'll find out whether you have prostate cancer is you'll just go in for routine screening. If you go and get a prostate exam and you feel that the prostate's a little difficult, right? So a little firm because of that neoplasia, after you've entered into the rectum and felt that prostate, well, one of the things that you'll do is you'll go and get a PSA. So it's a prostate-specific antigen test. And when you're doing that, the problem is this is a antigens of the prostate, and antigen-specific prostate-specific antigens that are going to be normally circulating. There's always going to be a little bit of autoantigens floating around there. So the PSA level is generally going to be indicative of cancer when we're on that higher end. But the problem is anything that irritates a little bit of prostate tissue and causes that prostate tissue to be either become inflamed or to have a little bit of apoptosis or necrosis, that's going to lead to more prostate-specific antigens, right? Literally just riding a bike can increase your PSA levels. You don't have cancer, you've just irritated the prostate because you've been sitting on it. So lots of different reasons might increase this. The test is generally not that specific. I have this little video that I'd like you to watch. This is the problems there's a whole raging debate on whether or not people should even be treated for prostate cancer, just because so many prostate cancers are not actually that infectious, or are not actually that malignant and have some mortality associated with them. So I want you to go and watch that, but I don't want to kind of take up time with this. It's just a nice little video to talk about why you should test sometimes and why you shouldn't test. Why would you test if you're not going to treat it? You might as well not test. So this is useful for understanding some other cancers as well. So I wanted you to be able to have access to it. So once you do have a digital rectal examination that shows you some firmness and you have a high PSA showing, hey, maybe there might be a lot of cellular necrosis going on inside the prostate, what you'll do is you'll get a prostate biopsy. And what they do is they do these little biopsies and they shoot little needles into the prostate and get these cores out of it. And they'll look at those cores and look for metaplasic or neoplasic cells, so cells that kind of don't really look all that right. Something's gone wrong. They're odd shapes, odd sizes, that sort of thing. And they take a 12 series of cores from the prostate itself, and right, you can see where the urethra would flow through the prostate here. And in doing so, you can kind of give an estimate of how serious this cancer is. The way you do this is generally you're going to do a transrectal ultrasound. So you're going to stick an ultrasound wand into the rectum itself, into the anus, and then that's going to guide these syringes. And I have a little video that I want you to watch a section of. So just to see how this actually works. So here's a little video. So they're going to, you can see this, they're clearing away and using that transrectal ultrasound and what they're doing now is they're actually going to be doing a little bit of lidocaine so that this area is not going to feel as bad, lifting the testes up obviously out of the way, and they're going to do some punches through, and they're going to punch in and be able to watch where that needle is going so that they don't delve too deep. And you can kind of see how this is happening in real life. So just wanted to show you a little bit about how this works. And then once they have anesthetized the area enough, they're going to drive in and get their samples out of the prostate. A lot of times they can put this little card system up in front of it that you're going to see in this picture. So they use these little guidelines to actually make sure that they're getting the prostate itself. Part of the reason why not many people do this is obviously it's a very uncomfortable screening procedure, but obviously even if you do get results that are positive, most medical doctors or most doctors are not really going to intervene because these are generally not very aggressive cancers. But this gives you an idea that you need to check in a little bit more frequently on this prostate to make sure that the cancer is not developing too rapidly. The last thing that we're going to talk about is Polycystic Ovarian Syndrome, or PCOS, P-C-O-S. PCOS is one of the main reasons that people find out that they have PCOS is when they're having infertility issues and they go and seek understanding about what's going on with their infertility. And it's a very complicated thing. It's something that it's actually probably a couple different diseases that are all lumped into one. That's why it's considered a syndrome and not a disease. But what's going on is you get this kind of endocrine storm where you end up having too many androgens. So things like testosterone will rise, and then those androgens tend to suppress and have a declining effect on luteinizing hormone, but simultaneously an increase in follicle stimulating hormone. Now remember, GnRH being released by the hypothalamus stimulates the anterior pituitary to release LH and FSH, but you get this disconnect in polycystic ovarian syndrome. So you end up stimulating the follicles, but without the luteinizing hormone, you never end up actually having that follicle erupt and ejecting that egg. So the follicle tends to grows, but then it never ovulates. So you get anovulation, leading to these big giant cysts, which are not infected, and it's not cancer, it's just a giant follicle that never ruptured. So let's do a little drawing to put this in perspective. Right. So in PCOS, we have a couple different organ systems that we need to understand and need to kind of put in context with each other. Right. So we have the hypothalamus, we have the anterior pituitary, we have, and inside the anterior pituitary, we have the follicle itself, inside the ovary. And the follicle actually is made up of a couple things. It's made up, of course, the egg, and then also we have some endocrine tissue around the egg, and that's what the whole follicle is. So the egg is not actually going to be all that terribly responsive, but the theca cells, it's supposed to be an A, theca cells, as well as the granulosa cells. So these groups of the follicle, so the follicle is all of this, including the egg, well, they're going to be responding to this sort of axis. And the way that this is supposed to go is we're supposed to have the hypothalamus. The hypothalamus releases GnRH, gonadotropin releasing hormone, and that stimulates the anterior pituitary to release its own hormones, things like luteinizing hormone, as well as follicle stimulating hormone. And follicle stimulating hormone tends to have a strongly stimulating effect on granulosa cells, and luteinizing hormone tends to have a strongly stimulating effect on theca cells. So the way that this works is these theca cells, in response, are going to generate their own hormones. They're going to generate things. The theca cells make androgens, the dominant one being things like testosterone, and the granulosa cells are going to make things like estradiol, the predominant form of estrogen. Well, when estradiol comes into the system, estradiol obviously is going to be the thing that is actually the way that we turn this system off. And under normal development, as this egg gets bigger and bigger and bigger, more and more estradiol gets made, and then we end up shutting off the production of GnRH that ends up allowing only one follicle to develop. That's the way that things are supposed to go. It's a strongly inhibitory signal. The problem is, in individuals with PCOS, we either have an external endocrine system that's causing problems that we're going to come into right now, or just we have this pathological system where under normal circumstances, the GnRH that's being released is supposed to be something that's released in a kind of pulsing wave, right? You have a rise in GnRH, and then that GnRH is inhibited by estradiol, and then estradiol starts to descend, GnRH starts to be produced in more high quantities. Well, in polycystic ovarian syndrome and PCOS, what's actually happening is we end up having a accelerated exacerbation of this frequency. So an increase in frequency of GnRH means now all of a sudden GnRH levels are a little bit higher, and that tends to stimulate, just like it stimulates the normal amount of GnRH stimulates FSH and LH. So you end up getting this pathological stimulation, but the problem is LH ends up being more stimulated by this expansion or by this increase in frequency of GnRH. So yeah, you turn FSH on and you end up getting a little bit more estradiol, but you turn the LH on more, and so theca cells end up producing way more androgens. So you end up throwing off the ratio of androgens to estrogens in this patient. And when this happens, you end up making a little bit more estradiol, and some of that is going to have a rise in androgens, is generally going to have a difficult time ovulating. So this ovulation tends to be kind of stunted. So you end up never actually moving over into something like the corpus luteum. The corpus luteum is going to be that follicle after it's ovulated. And without that corpus luteum, you lose the progesterone. Oh, that should be in red. We'll imagine that that's in red, right? Progesterone is that hormone that's being produced by the corpus luteum. And then corpus luteum, and then that progesterone is the thing that's really profoundly negatively inhibitory, right? So progesterone is a really powerful inhibitor of this axis. But in PCOS, what's happened is you end up not ever ovulating. And so you end up never developing the corpus luteum, you end up never producing progesterone, and you lose this regulation, which tends to kind of be a really negative feedback cycle. This just gets worse and worse and worse. The frequency tends to increase more, and this starts to exacerbate. It gets worse over time. The other thing that we have to talk about at the same time is the pancreas in PCOS plays a role. Well, pancreas produces, obviously, it produces things like digestive enzymes and glucagon, but in this system, the thing that's important is it produces insulin. And insulin is going to do things that control, obviously, our blood sugar, but insulin also has a stimulatory effect on luteinizing hormone production. So we make a little bit more luteinizing hormone. So somebody that has a rise in insulin could start to see a rise in luteinizing hormone that tends to tip the balance more towards androgens than estrogens. So the insulin itself could cause this imbalance and then exacerbate this PCOS and make this worse. But making this even worse is the fact that androgens have the effect of actually causing insulin resistance. As androgens increase, right, you start to become a little bit more resistant. Well, what are you going to do if you start to become a little bit more resistant to insulin? You're eventually going to make more insulin. As your insulin levels rise, the pancreas starts to kind of peter out and not be able to make as much insulin. And oops, we've already slipped into type 2 diabetes. So type 2 diabetes, because of an excess of androgens, because of PCOS, is now going to mean that, well, now type 2 diabetes is, as you're slipping into this, now that means that you're increasing the amount of insulin that you're producing because of this insulin resistance. So now all of a sudden it's getting worse and worse and worse, right? More insulin tips the balance even more towards androgen production over estradiol production. Again, exacerbating the system, making it even worse. So this is why PCOS is kind of a very difficult cycle to interrupt. One of the ways that you can do that is going to be to give artificial progesterone, right? So you'll replace the progesterone that was lost because you never end up developing corpus luteum. You end up giving someone things like the pill, right? The birth control pill that contains progesterone. And that's one way to try and hopefully rein in this exacerbated cycle. So this hyperandrogenism, right? Too much androgen, too much testosterone leads to things like acne. Obviously, acne associated with a rise in these androgens that we see in things like puberty, but even after puberty with polycystic ovarian syndrome. Leads to infertility issues, especially in females, insulin resistant, and then hirsutism is hair growth, like facial hair growth in women. You can see old cases of hirsutism of people that are covered in almost like a full sheet of body hair. That's going to be all because of those androgens, things like testosterone. So part of the problem with polycystic ovarian syndrome is it's kind of a chicken and the egg situation, right? Where insulin can drive this androgen production, And then androgens make the insulin production go up as well, right? So you could certainly have somebody that is developing type 2 diabetes, right? It's in the process of developing type 2, and then that is the way into this system. Or you could have somebody that has just a kind of pathological increase in GnRH secretion. So it could be a GnRH problem that leads us into this, but then will eventually kick us out into type 2 diabetes. If we start with type 2 diabetes, it can eventually kick us out into a GnRH problem. So it's kind of very much a chicken and the egg situation. It's kind of a difficult thing to manage and a difficult thing to identify. It's often misdiagnosed. So that is it for the course. I will see everybody on Friday. I'm going to post as soon as I can. Been a pleasure talking with folks. I hope everybody's learned a fair bit.